go to the first slide. Can you see the slides?
No.
No.
You have to do share screen.
Yes. I was in the, okay. I was within the meeting, but now I'm not.
At the bottom of the screen is a share little green symbol that says share screen.
I'm pushing the button of sharing, but now I cannot. I cannot open the.
You have to open your PowerPoint at the back, and then you press the green button to share screen.
I open on my screen the okay. This one, okay. Okay, now
We don't
condividi
see it
presentation,
yet.
screen, condividi. Okay.
Okay. Now.
Okay.
Now we see it. Thank you very much.
I'm sorry. Many thanks for the scientific committee for the kind invitation, and many thanks to Evelyn that warning me for the change of our. In CKD patients, several metabolic and clinical factors may negatively affect nutritional status and lean body mass, leading to frailty, protein energy wasting, sarcopenia, up to cachexia. Protein energy wasting is characterized by loss of protein and energy stores associated with multiple metabolic derangement. Apart from an inadequate spontaneous nutrient intake, several other factors such as metabolic acidosis, insulin resistance, chronic inflammation, intestinal dysbiosis, infection, oxidative stress are also contributive to protein energy wasting development, poor muscle function, and loss of lean muscle mass. A reduced muscle mass appears to be the most valid criterion for the diagnosis of protein energy wasting, but it is always not easy to detect with accuracy lost muscle mass or muscle loss. Skeletal muscle abnormalities in chronic kidney disease have been described over half a century ago under the term uremic myopathy. That has an overall prevalence up to 50% in dialysis patients. Muscle weakness, defined as a failure to generate force, is quite common in CKD patients. This slide shows the force of maximum voluntary isometric contraction in a cohort of peritoneal or of hemodialysis patients, and the shaded area represents the normal range. But apart from functional changes, variability in fiber size frequently occur in CKD and in a greater extent in end-stage renal disease patients. Evidence exists that the most common abnormalities in uremia are type 2 fiber atrophy, small cross-sectional area, and type grouping. Type 2 fiber cross-sectional area of uremic patients are smaller than the healthy control. This change was less evident for type 1 fibers. Considering type 2 fibers, the subtype B showed higher degree of atrophy than subtype A. Moreover, the difference was more evident in the malnourished patients. Muscle biopsy studies in patients with CKD reported a decrease in muscle mitochondrial oxidative enzyme, muscle cytochrome C, oxidase activity, and citrate synthase, and a decrease in the synthesis of muscle proteins, myosin heavy change, and mitochondrial proteins. The synthetic rates of muscle proteins and activity of mitochondrial enzymes were negatively correlated to the severity of kidney disease. Muscle wasting is common and is progressive in patients with CKD. The decrease in muscle mass involves both a decrease in muscle fiber size and in number. Either atrophy or hypoplasia are attributed to muscle protein wasting and its multifactorial etiology, including hormonal, immunological, and myocellular changes, chronic inflammation, metabolic acidosis, reduced protein intake, and physical inactivity. The most important pathway of muscle wasting is the ATP-dependent ubiquitin proteasome system, but is not the only one. As shown in this slide, a number of potential intracellular signaling processes are involved in uremic muscle wasting that appears to be multifactorial in nature. Chronic kidney disease leads to increased skeletal muscle fatigue, weakness, and atrophy, and it has been attributed to abnormalities in skeletal muscle mitochondrial energetics. Tom et al. Showed that uremic toxins negatively impact skeletal muscle mitochondrial energetics, resulting in decreased energy transfer, impaired complex 3 and 4 enzyme activity, and elevated reactive oxygen species production. Non-dialysis dependent CKD patients exhibit reduced skeletal muscle mitochondrial mass and reduced gene expression of the transcription factors involved in mitochondrial biogenesis compared to INTI control. These changes were not affected by 12 weeks aerobic exercise or combined exercise training that fail to increase mitochondrial mass or complex protein abundance, citrate synthase activity, and OXPHOS protein complex. This systematic review and meta-analysis of randomized controlled trials, including studies of at least 8 weeks duration, showed that regular exercise training generally is associated with improved health outcomes in patients with CKD, namely aerobic capacity, muscular strength, and walking capacity. Instead, smaller body of evidence exists about the favorable effect of exercise training on muscle mass. The effect of exercise on muscle atrophy of hemodialysis patients was reported in this study in the late 90s, where a small number of hemodialysis patients underwent a rehabilitation program, and therefore, and before and after 6-month exercise period, open muscle biopsies were taken from the vastus lateralis muscle for histological examination. All patients showed impaired exercise capacity, which was associated with marked muscular fibers atrophy and reduction in muscle strength and nerve conduction velocity. All type of fibers was atrophied, but type 2 was affected much more than type 1 ones. Tissue examination showed severe degenerative changes in skeletal muscle fibers, mitochondrial, and capillaries. But following exercise training, an impressive effect on muscular atrophy was observed. In particular, the proportion of type 2 fibers increased by 51% and the mean muscle fiber area by 29%. Positive changes were also seen on the structure and number of capillaries and mitochondria. These results were confirmed when the morphology of the gastrocnemius muscle histology was assessed in 9 hemodialysis patients who underwent muscle biopsy before and after 6 months of aerobic exercise training. When compared to the pre-training status, the mean cross-sectional fiber area increased by 46% after training, and it occurred for all types of fibers. Accordingly, the proportion of atrophic fibers decreased significantly after training in type 1, type 2A, and type 2B fiber populations. Significantly differences were also found in capillary contact to fiber ratio, with an increase of 24% in respect to the pre-dialysis status. Additional data on the efficacy of exercise in order to reverse, or in part at least, muscle atrophy in end-stage renal disease patients came from the study of Kirkman and co-authors who used the progressive resistant exercise training method. It consisted in a training volume increasing from week 1 to 12 that resulted similar in both hemodialysis patients and healthy controls, although it was lower at each time in hemodialysis than in the control subjects. Evidence arose that hemodialysis patients and healthy people progressive resistant exercise training induced a similar anabolic response as assessed by the changes in tide muscle volume. When resistant exercise was coupled with high protein nutritional supplementation, significant benefit on muscle strength and physical performance occur in dialysis patients, while not significant results was found on muscle mass. On the other hand, protein-restricted diets are the mainstream of the nutritional therapy of non-dialysis dependent CKD patients. Castaneda et al. Planned a well-designed randomized controlled trial to assess the efficacy of resistant training in improving protein utilization and muscle mass in 26 patients affected by chronic renal insufficiency on a low-protein diet, namely 0.6 gram per kilogram of body weight per day. These patients were randomized to receive or not resistant training program. In patients who perform resistance training, total body potassium as a surrogate of total body cell mass increased by 4%. Type 1 and type 2 muscle fiber cross-sectional areas by 24%, and type 2 fiber cross-sectional area by 22% as average. Also, muscle strength was similarly increased. So the conclusion was that resistant training, even when coupled with protein restriction, was able to improve muscle mass and nutritional status in patients with CKD. These findings were not confirmed in elderly CKD patients not on dietary treatment after resistant training program. The author found that muscle histopathological abnormalities were already detectable and that an increased muscular strength and endurance was possible in elderly patients with chronic kidney disease after exercise training, but it was not effective in increased muscle fiber area or to change muscle fiber type proportion at histological examination. More recently, Klein and co-authors investigated the effects of a long-term 12-month exercise training on sarcopenia, muscle mass, and plasma myostatin level. A large cohort on 151 non-dialysis dependent patients, stage 4, the average of GFR was 23 ml per minute, were randomized to higher strength or balance training in combination with endurance training. Dual energy X-ray absorption was used to assess the changes of body composition. After 12 months, leg and whole body limb mass increased significantly in the balance group and remain unchanged in the strength group. Whole fat mass decreased significantly in both groups, while there were no significant between group differences in sarcopenia or body composition. Plasma myostatin levels increased significantly in both groups, with a significant difference in favor of the strength group. Myostatin was related to muscle mass and physical performance. So my final consideration are the followings. Patients with moderate to advanced CKD have decreased muscle mitochondrial content and oxidative capacity, along with suppressed activity of various mitochondrial enzymes, such as mitochondrial electron transport chain complexes and pyruvate dehydrogenase, leading to impaired energy production. The damage induced by uremic toxin, oxidative stress, and systemic inflammation have been implicated in the development of mitochondrial dysfunction in CKD patients. These changes are detectable since the early stage of CKD and correlate with the severity of the disease. Aerobic exercise, a well-established strategy to improve muscle function and mass in healthy adults, is not as effective in patients with advanced kidney disease. CKD is associated with muscle breakdown and decreased muscle protein synthesis due to a number of factors, including uremic inflammatory environment of the disease. CKD patients are highly sedentary and at risk of malnutrition, which may exacerbate sarcopenia outcomes even further. Data also suggest that renal patients may require increased resistant exercise intensity and progressive loading to obtain detectable results on muscle atrophy. Short and long-term exercise and nutritional intervention are also found to have a positive effect of sarcopenia in CKD, but several questions are still open. For example, the dose and direction of exercise, the exercise setting, the amount, quality, and timing of protein intake, and so on. Muscle hypertrophy is induced by progressive resistant exercise that activates the serine threonine protein kinase mTOR complex 1, which regulates various cellular processes, including protein synthesis. But this pathway may be influenced by a proper nutritional approach, which differ between CKD and end-stage renal disease patients. Accurate exercise training and correct nutritional therapy may be a successful strategy for CKD and end-stage renal disease patients to prevent or correct muscle atrophy. Thank you for your attention.
Thank you, Professor Cupisti, for your excellent presentation.